question about the acute leukemia talks, both for Roland and Farad. The problem is always when the patient fails 2 induction therapies, relapse or resistant. And these induction therapies often includes high-dose RC with salvage therapies. And the patient is young enough for a transplant, but is not, as you said, the best candidate for a transplant because the outcome is not good. So the options are very limited as of now. So we often go to clofazimine, which is, in my opinion, not a very successful drug in that situation. The transplant is done on a almost charity mood because we don't have. So the options are. So I'd like to know your opinion on whether an intense chemotherapy, which is what we do sometimes, but I don't think there's many studies showing that, making the patient aplastic and they'll have the transplant at that point when closing your eyes, and then does it make sense? Is it data to support that strategy, which is a kind of a popular but not very scientific? And the second question is, you said for secondary AML, if what you said, actually you showed that the secondary AML may depend on a genetic predisposition that is independent of the chemotherapy. So patients may actually be predisposed to a secondary AML even prior to being treated. So the question is, should patients with breast cancer or colon cancer or solid tumors be tested for this genetic predisposition prior to their chemotherapy and being monitored for monitoring the mutations after the chemotherapy, not to get to see if they have an early diagnosis of leukemia?
So I'm going to answer the second question first. I mean, obviously, that's something that would be desirable to do particularly if you have an effective strategy. I think it would be a little bit premature to do that now, because all we probably will do is increase the anxiety of the patient and tell them that you have a predisposition to develop therapy-related AML. We're going to give you a breast cancer therapy, and we're going to keep watching you. I think it's something like MRD, probably 10, 15 years ago. When you don't have effective strategies, some of these should only be done only on a research basis with consent from the patient, and with the patient knowing that we're going to increase their anxiety throughout the period. And if we don't have any effective strategies, I personally don't think if you find these mutations, you should refer them to our allogeneic stem cell transplant to prevent them getting leukemia. Am I making sense? So, because the risks, in my opinion, completely outweigh the benefits, potential benefits.
But sorry, most of these patients will develop MDS prior to AML. So you could actually diagnose an MDS prior to, but that's another discussion.
Well, yeah, I mean, again, that's something that we can envision in the future, that we potentially identify these patients, and hopefully in the future we will have effective strategies. Even if MDS, if you consider MDS, decitabine and azacitidine are not effective cures for MDS.
Transplant.
Yes, but yeah, I mean, that's the reason why I showed that data, that's what we envision, that we could potentially identify these patients, and hopefully in the future we'll have effective strategies. In terms of your second question, yeah, I mean, I see this all the time, unfortunately, and quite frequently in younger patients. For whatever reason, they're refractory to initial therapy. I think refractoriness is a very relative term. I published that if you're refractory to a high-dose RC-based induction, your outcome is dismal. Whereas if you're, and not just us, others have shown that if you're refractory to 3+7, you can actually achieve a remission by a second course. Giving up is a very relative term. Refractoriness is a very relative term. The most important thing to remember is nowadays we have potential targeted therapies. So I see these patients who have had 2 cycles of 3+7 and 5+2 and come to our institution, and we do a molecular testing, and we identify them as having IDH mutation or FLT3 mutation, and they easily go on to a strategy and they achieve a response and go and get a transplant. So that's a very important thing to consider when you see these patients. There are a subset of them that have these potentially targetable mutations, and as Roland said, the list of potentially targetable mutations is going to increase, hopefully. And the other strategy that we have used, and we've submitted an abstract to ASH, is it's only useful for younger patients. We give 5 days of decitabine, followed by intensive clofarabine, idarubicin, and cytarabine. It's sort of priming strategies. There is not a lot of good scientific data. There was a study by Eric Feldman and Cornell that did similar thing, plus 3 decitabine, 5 days of decitabine, followed by 3+7. But in our hands, in these younger patients, we have had very high response rate and very good success rate of getting them into a transplant. But I agree with you, there is the other strategy, but you're also looking at using a very intensive strategy and trying to transplant them on day 21 when they're aplastic. There's not a lot of data. There's a few small studies on that. I can't really comment further on that. I don't know if Roland wants to say.
No, I think you may have been referring to this German study that made this argument that would be valuable to get them into ablation and transplant them early. We're trying to replicate this. It took a long time to convince people to actually try this. So,
Dr. Venugopal.
Promise I will make it short. So the data on CPX351 you presented, I mean, it's very impressive. In fact, I listened to the ASCO presentation by Dr. Lancet too. I mean, at every level, cell lines, mouse marrow, phase 1, 2, 3, it's so impressive. And the phase 3, almost every criteria of response has been satisfied. So I'm just wondering what exactly is the secret behind it. Is it just a liposomal formulation like amphotericin, getting the drug to the right place, or are these cells having unique features like in older patients with AML, we know MDR expression is high, you have the PGP protein expression high, and anthracycline works better. So do we know something about the secondary acute myeloid leukemia cells that make it sensitive to this drug?
So I think the answer could be very short to say you don't really know. But there's a few sort of things that people are debating. One is that one of the premises how this drug got started was this observation in the lab that if you play around with different concentrations of the cytarabine, the daunorubicin, that you're getting different levels of synergism and sometimes maybe even antagonism between the two drugs, right? And so one of the premises is that this liposomal formulation maintains what they identified as sort of quote-unquote optimal ratio between the two drugs for a longer period of time. So I think whether that turns out to be a reason, I think no one really knows, but that was one of the premises. The other one, I think, there's for leukemias that express P-glycoprotein or other drug pumps, there's at least some old data that said you could overcome that resistance by continuously exposing them to an anthracycline. And it's at least theoretically possible that by offering a drug that doesn't do this, but has sort of a longer persistence of higher levels, that you might be able to overcome some of that relative drug resistance.
Do we know in secondary leukemias PGP expression is high?
Yeah, I think that's well known. I mean, I think the prevalence of this goes up by age and by other unfavorable characteristics. That's well known, yeah.
Thank you.
Yeah,
Just to comment that it's actually a little bit sad that in AML we have become so used to negative studies that when we even see a positive study, we're always shocked and, as this is not true. And this is why in myeloma they have like 15 drug approvals in the last 15 years, and in AML we haven't had any, and we only had one since 2000 that was withdrawn. So hopefully things will change, and we become more optimistic, and we'll get more drugs.
I have two basic questions. One for Dr. Rawandi and Dr. Walter. So, in acute myeloid leukemia, day 14 bone marrow, how useful is that? Do we really have to do day 14 bone marrow?
Oh, that's a charged question. So I think for the high dose cytarabine-based regimens like Dr. Rawandi is using, there's probably no value of it. I think that's published enough that the marrows change over time enough, even without giving more therapy, that you're underestimating what you're doing. Whether it's that useful for 7+3 therapy, I think that's a bit more open. I'm sort of skeptical that you're learning a whole lot from it. I think I'm more curious whether there's a benefit of double treating versus a single, like, for example, the SWOG approach has been to give one cycle and then to retreat if there's disease, whereas a lot of the German or other European groups give double inductions. I would be more curious whether there's a value there. There's certainly, I mean, it's clear that if you're making decisions on day 14 based on blast counts, that you're potentially treating people that would have been in remission at the end of your cycle 1. Because it's also documented that not every patient with residual disease on day 14 will have residual disease at the end. Now, it does provide some prognostic information. If you have more blasts at this early time point, it tells you something about later on. But whether there's a benefit of giving treatment, that's a different question.
Okay.
So I think it's open.
Another question for Dr. Deininger. So CML being a chronic disease now with most people surviving 5, 10, 15 years. There's a question about second primary malignancies. And there have been conflicting data with imatinib. What are your thoughts about it? Do you think that is a significant concern in these patients? Do you think one agent is superior compared to another one in terms of long-term toxicity such as this?
I think these are two different questions. So one is related to secondary malignancies on imatinib, and I don't think there is much really convincing data to support that. There's one study called the ILTE study that is multi-institutional, international, that looked at patients with complete cytogenetic response for at least 2 years, and then looked at outcomes, so overall survival, but also quality of life. And there really was no signal for increased secondary malignancies compared to age-matched controls. So I think, to me, that is almost the definitive study on that. The second question is more difficult. I think what we see with nilotinib, maybe a little bit with dasatinib as well, is that for some reason we don't make gains in overall survival. So that means we are losing patients for one or the other reason. Maybe it's cardiovascular risk, maybe it's infections with dasatinib. So I think these very potent TKIs are not innocuous if given for a long time. Whereas imatinib, as far as we can tell, the side effect profile that we knew about at 5 years has really not changed much. So despite now almost 20 years of experience, we're not seeing anything, as far as I can tell, dramatic that we haven't known before. So I think you have actually 3 parameters going into that. One is imatinib is a good drug, but it has a lot of grade 1 and 2 toxicities. So I think it has quality of life issues. This factor number 2 is, I think you have more significant, really medically important toxicity with second generation TKIs. And thirdly, there's the issue of, can we stop treatment, and are the second generation TKIs going to facilitate that for more patients? So can you put that in the equation? Can you say you induce people with a second generation TKI, and then you're able to pull off those people, get a complete molecular response before they run into any drug-associated toxicities. So we're not, in other words, reserving the TKIs for those who really need it. And I think we need to do the right trials to really understand these questions and then answer these questions.
Sure, thank you.
I have a question for Mike. Do you know if there's any PK study that could be done or to correlate the level of these drugs with the outcome, with the response rate, the outcome and possibility to stop it? Because it's quite, it's a fixed dose for one fits all, which is kind of weird.
So there are PK studies on imatinib, actually quite fairly extensive, but everything is about 5 to 8 years old. But there is one study actually from France that looked at imatinib levels and subsequent molecular responses. And I think this is the only interventional trial. So they did PK, I think, at 28 days. And then in those patients with a low drug level, escalated the dose and then compared subsequent molecular response and found a significant advantage. Now, I don't think this has been published yet, but I'm aware of the data. So you could extrapolate from that and say that more people with this adjusted dose will achieve a deep molecular response and will then qualify for discontinuation. I would say one always has to accept that it is a bit of a leap of faith, because the drug levels in the plasma may also reflect the drug levels, may reflect the host, but could also reflect some disease biology. So I think it's not easy to totally separate that without actually knowing what it would mean to discontinue if you needed a high dose of imatinib to achieve a good response, as opposed to getting there with a low dose. So I think that's just this qualifier. And then I think the other part of the equation is specifically for dasatinib, there is emerging data that, especially in older people, the currently recommended dose is probably quite a bit too high. So these people have higher drug levels than expected. And so I think, especially for dasatinib, there's probably a lot of downward space. And we have quite a few patients on 20 milligrams who, remain in complete molecular response, have very little side effects. So maybe this is another thing to explore.
Thank you so much.